Welcome to the Medical Minute podcast. I'm Anne Connell, a Melbourne-based GP.
And I'm Moz Califella, also a Melbourne-based GP. On today's episode, Dr. Anne, we are doing some rapid fire flying through some really important and significant news updates. There's actually been at least two that are extremely exciting, and the third is pretty important as well. So today we're going to cover a huge update for women who have bacterial vaginosis and some important updates around the PBS around both contraception and hormone replacement therapy.
Yep. And before we go any further, I'll remind everyone that, as always, a podcast can't replace individual advice from your healthcare practitioner, and this is education and hopefully entertainment. Yeah.
Absolutely. So let's dive straight into the first one, which is actually a pretty significant research paper by a very local group of clinicians over at the Melbourne Sexual Health and Reproduction Centre. What did they have to say about bacterial vaginosis, Dr. Anne?
Well, after telling us since the beginning of time that bacterial vaginosis was an overgrowth situation and definitely not sexually transmitted, we now have evidence that it is indeed a sexually transmitted illness.
Absolutely. So for those who are unfamiliar with bacterial vaginosis, as you've said,
Lucky
Dr.
them,
Anne,
lucky them if they're unfamiliar.
lucky
yes.
them. It is primarily a disease that the women are going to have symptoms of. Blokes don't often have symptoms of bacterial vaginosis because they lack the vaginosis bit. But essentially, it can cause some degree of discharge. It can cause some discomfort. It can cause some itch. Occasionally, it can cause some bleeding. And often we will diagnose it and will treat the patient with some version of antibiotic. The study actually found that treating the patient and treating their male partner improved the success rate of treatment, didn't it, Dr. Anne?
It did, which is startling because some poor souls have recurrent bacterial vaginosis, and it's all the things that you said and more. Women are sometimes plagued by having. They feel a horrible smell from the vagina. It's supposed to have a horrid fishy odor, and the vagina can actually be uncomfortable. Just doesn't feel like their own. Just a constant awareness of a degree of discomfort in the vagina, watery, slightly fishy smelling discharge, and just not feeling comfortable in your own body. So these poor souls have had multiple courses of antibiotics, whether it's by mouth or topically through the vagina, but their misery has continued. But this study at our own Melbourne Sexual Health Centre looked at treating the male partner. So the study, we should stop and say the study was of people in a monogamous relationship, male, female, so penis and vagina sex, and they got the woman to take standard treatment, but they also treated her male partner for a week, both with a course of antibiotics by mouth and a cream to be used on the glans penis twice a day for a week. And they stopped that trial early, didn't they, Moz? Why did they do that?
Because essentially the treating the boys was so ridiculously effective that it was unfair to continue to not treat the male partners of the other women that were in the study. So I think the numbers were something like at the 12-week mark, or when they stopped around that 12-week mark. What were the recurrence rates, Dr. Anne?
So for women whose partner was treated, the recurrence rate was 35%, which is still 1 in 3. But for women whose partner wasn't treated, the recurrence rate was 65%, I think. I'm just having a little look here. I think, to
oversimplify that, really you're talking about a third coming back versus 2/3 coming back.
Yep.
So that's a really big drop in how many women we're seeing who are going to have these symptoms. And so, of course, they stopped the study because they were like, well, it's not actually fair to – we now know that this is actually making a huge difference, so we can't just ignore these other poor women who are suffering. We should offer treatment to their male partners as well. And so they've just published that study, I think, at the time of recording, something like within the last few days. So this is a very well-timed study for this podcast recording. But very exciting. And I think there's been a lot of chat on social media and in sort of medical spheres that many people sort of feel this is a very exciting piece of news.
It is, absolutely. And it will, as of now, that will be our standard practice, that we will be recommending women who have bacterial vaginosis get their partner treated as well. Interesting that for the girls, they can use either the cream or the antibiotics by mouth. But for blokes, the recommendation is that they do both of the things.
Mm.
Yeah, definitely interesting, fantastic news. More or less halves the risk of recurrence. And so people might be surprised that even with treating both partners, the recurrence rate is as high still as 35%, although it's way better than 60 odd percent. And I
Yeah.
guess that's because we need to understand that the bugs involved in bacterial vaginosis unfortunately are bugs that are typically found in the vagina, that whether we like it or not, all of our body orifices have bugs that just live with us. Yeah.
Yeah,
And
absolutely.
it is an overgrowth situation, but it seems to be that the biome of the glans penis is significant. Yeah.
Yeah.
In the introducing somebody else's bugs, even if of the same family, seems to materially increase the risk that you get the overgrowth. So we would still love to get to the point where we could get rid of it more effectively than a recurrence rate of 35%. But a halving of the recurrence rate is absolutely meaningful and wonderful news. Yeah.
And I mean, optimistically, I think that there will be more improvements to be had, but just not right this very second. And so I think we should celebrate the improvement that we have
Oh, yeah,
right this moment
absolutely.
for
I
sure.
mean, and we can speculate because we know that in recurrent vaginal thrush, which is a somewhat similar situation that you have an overgrowth, but then it's of the yeast. Then we find that for women who get recurrent problems, then actually treating them long term, maybe them taking something every week or every month to stop it. And maybe we will find that there will be a sweet spot of treating both partners, pulling numbers out of my head, 4 times a year might actually stop this misery happening.
Yeah, absolutely. And
Um,
I think the other thing worth noting as well, so this particular study, as you highlighted already, Dr. Anne, was looking at females with in monogamous relationships with male partners, specifically looking at penetrative intercourse between vagina and penis. But they've already launched and there is a study underway at the moment looking at other modalities of sexual intercourse and specifically looking at the LGBTQI community and seeing whether we see similar patterns in terms of treating the other partners of the unaffected patient. So it'll be interesting to see what those studies show.
Yeah, and logically, you would expect that the same benefit would whoever your partner is, that I am getting them to clear their biome and would work. But it's appropriate to make sure that we are right. We can speculate, but we need studies that prove that what we think is actually borne out in practice. But
Mm.
it's exciting stuff, and it is a condition I think that causes a good degree of misery if you always feel somewhat unclean, that you always feel slightly smelly, slightly uncomfortable. So it's great, wonderful news that there's treatment available for the poor people who get this miserable problem. So well done, the Melbourne researchers. I think the last couple of pods we've been go as Australians, eh? And I am Australian in case anyone's in any doubt. 2 passports, definitely Australian.
So the second agenda item for us today, Dr. Anne, is on paper at first glance a very boring one, but actually the first time that I pulled this out in consult, the woman actually almost practically squealed, to be honest. And so from the 7th of Feb in 2025, essentially now there has been a huge increase in some PBS spending, and what has come onto the PBS, which is obviously the taxpayer-funded medication list. So what has come onto that PBS list, Dr. Anne?
Well, for the first time in 30 years, some new contraceptive pills are PBS funded. 30
Absolutely.
years was the last time, yeah. So even by the government's own data, up until these new things were put onto the PBS, fully a third of women under 40 were using a non-government funded pill, oral contraceptive pill, because the ones that were available on government prescription did not suit them for some reason. So it's great news. So that specifically, there's 2 pills have come on, and I guess we can call them by brand name because otherwise people won't know what they are, but it would be Yaz and Yasmin.
Mm-hmm.
Those are the 2 pills that have come on to government prescription. And that really will save people a lot of money. So before they were on government prescription, your cost for a 3-month prescription was in the ballpark of $80, $85, depending on where you got it. Now you will be able to get your 3-month supply for your typical prescription cost, which will be $31.60 if you're a general patient and $7.70 if you're a concessional patient. So that is really meaningful. Still not as cheap as the old pills. Some of the old pills are down to $10 for a 3-month supply. But if not everyone is lucky enough for the traditional standard pills to work for them.
And I think it'll depend as well on your patient demographic as well, won't it, Dr. Anne? So I think most of my patients would be on some version of these newer ones. And so I think there's a lot of women that are going to be extremely happy about this change.
As they should. So the standard pills, the older ones, the $10 for every 3 months pills, if they work, they all work for contraception. The issue is that for some women, the progesterone in the older pills just don't suit them. They get bloating, they get headaches, they get breast tenderness, they get moodiness. So there's a different progesterone in the Yaz and the Yasmin, and it seems to help for women who get those particular side effects, and also for women who get hormonal acne, that the Yaz and Yasmin seem to be meaningfully better than the standard pills. So it seemed unfair that through no fault of your own, you were either getting a side effect from the standard pills, or you had an additional problem that needed treated. But it was like, oh, well, you can't get a PBS funded prescription. So it is wonderful news that these pills have moved on to PBS. And as you say, we have girls doing happy dances in the room when they find out, because it's a lot of money, particularly when you're a young person with not a high income. To spend close to $30 a month on your contraceptive pill is not an insignificant amount of money. So good news.
This might change some of the chat we have around. I haven't run the numbers, but this might change some of the chat we have around some of the long-acting contraception in terms of cost, because we often tell people that it's far more cost-effective. All of a sudden, if you're a concession card holder, it may not be, and so this may end up being a more cost-effective method of contraception.
Yeah, we'll have to have a little look at that. Of course, Marina's played its trump card of having its lifestyle extended to 8 years. Not lifestyle, life expectancy. Currency? What's the word? Currency, I think is the word I'm looking for. Extended to 8 years for contraception. But yeah, definitely the numbers need run again. But it's very good news for all of our patients who require oral contraception. Again, gotta love an election year, haven't you, Dr. Moz? Usually there are prizes for everyone. Yeah,
absolutely. And this is in the show notes, but I wasn't aware of this, so perhaps you can tell me and the audience. There's some ongoing haggling around the cost of Slinda, which is one of the progesterone-only pills.
It is. So Slinda is the only new progesterone-only pill for decades. It's a great pill. I mean, I use it a lot. Do you like the Slinda?
I do like the Slinda. I prescribe it quite a bit, but I mean, where it's appropriate. So
yeah. So for people who are not aware of it, so many pills are progesterone only. They don't have any estrogen. But the downside of the traditional mini pills were that they were less effective in terms of contraception to your standard pill. You only had a 3-hour window for taking them, so you had to be really, really particular. If you're more than 3 hours late, you're on to missed pill rules. And your bleeding tended to be chaotic and you had no control over it. Often you had long time between your cycles, so probably longer than 30 days, but you just had no idea when it was going to happen. So
just surprise.
Surprise, yeah, surprise. Yeah. Here's your period, hooray. So with this Slinda, it's packed much more like a traditional pill. You've got your days that you're going to bleed and the days that you're not, your active pills and your inactive pills. It's got the same pill rules as your standard pill, so you can be up to 12 hours late and we're all good. And although you can't stack your packs like you can do with the standard combined pill, it becomes a moot point because within the year, like within 6 months, most girls are not having periods anyway on the Slinda. So,
the lining of the womb has thinned so much.
Yeah. So I think once it comes on to government prescription, it will become an equal offering. Well, for me, in my practice, I'm thinking it will become an equal offering to the standard contraceptive pill for girls when we're talking about the pill, because it's just as good. And yeah, what do you think, Moz? What?
Yeah, it's interesting. I don't often think about it as a first-line contraceptive option. I do talk about it for anyone, even if someone comes in, as a young teenager who's never had any version of contraception and we're having the first chat. I will cover the mini pill. I think one of the challenges is when you compare it with Yaz and Yasmin pragmatically, is I think that a lot more women experience things like acne, which can be a really deal breaker symptom for some women. It's obviously not all women who experience acne, but when you think about Yaz and Yasmin, where essentially one of the hero symptoms is, hey, we think that this will actually make things better with your acne, versus, hey, here's a medication that might make your acne worse.
Mm.
Most people will choose the Yaz or the Yasmin over the Slinda. But I do talk about the Slinda, and I think if it came down in price, it probably would actually be a really good first line
Yeah.
choice as well,
Yeah.
especially for women who can't use estrogen for one reason or another.
Absolutely. Or who don't want to, because there is a slightly increased risk of breast cancer, which we talk about with everyone with the combined oral contraceptives. So for someone who that was important, for whatever reason, to have the smallest risk, then Slinda is a great option. Although, as you say, if acne is already a problem or you get acne on the Slinda, then we may have to move you. Talk about moving you over to something like Yaz or Yasmin. But yeah, it's great that there are essentially more choices, better funding. Yeah, we are happy. We are very happy that
Wins
that
all
it's going
round.
to be available. Yeah. I think in terms of effectiveness for contraception, we probably still prefer our long-acting reversibles, or Marina particularly, but it's good to have more choices and for there to be more funding. So happy days and happy dances in the consulting room.
Absolutely.
As there are for the next thing, the next women's health thing that's been better funded under the new announcement in the election year, which is hormone replacement therapy or menopause hormone therapy. Yeah.
Absolutely. So maybe we'll talk high level, but essentially, I think, with the menopause hormone treatments, not a lot of options are available on the PBS. And then, of course, in the last, 12 to 18 months, there's been a huge shortage of many of the options anyway. So it seems like you can't get treatment for love nor money. And so one of the things that they've announced is, alongside the changes to the contraception, is they've added some things to the PBS as far as menopause hormone treatment, haven't they, Dr. Anne?
They have indeed. They've specifically added Estrogel and Estrogel Pro, which is the combination of the Estrogel with micronized progesterone. They have come onto the PBS as of the 1st of March. And indeed, I think I've done at least half a dozen prescriptions this week already for it. Yeah.
Flying through them, Dr. Anne.
There was a few patients were contacting me to get their PBS script because it's a lot cheaper. Yeah. So before, on private prescription, your month's supply of Estrogel Pro cost you $55.
Yeah.
And now that it's on PBS prescription, you get your month's supply for your $31.60 or your $7.70, whichever is the applicable rate for you. But once you're settled on the MHT, it is the same as any other long-term condition. 60-day scripts is a thing. So you can actually get 2 months supply for your one prescription cost. So that's gone from $110 for 2 months supply to $31.60 or $7.70 your concession card holders. So it has become within the reach of many more patients, and it's great news. Yeah,
absolutely. I think it's really, really great. And I think it's a fantastic move again towards looking after women's health with the current budget. So I think that should absolutely be celebrated. So I think I think it's very, very, very organized of you, but that is very on brand for you to have patients ready to rock and roll for the PBS announcement. I don't know if my patients can experience the same. I think I don't know that I'd be relying on me responding to those emails, but you can give it a crack and see how you go.
These are all patients that I've seen since the announcement came. Like, clearly, if you are scheduled to attend for a review anyway, get a new prescription, then I will. You will still have to come and see me because I have to check your blood pressure, check you're getting any side effects. There are things that we have to do. But these would be women who I've seen in the last 3 or 4 weeks, but who I just was physically not able to give them a PBS prescription because prescribing software did not allow, and it would not have been valid because they'd written before the 1st of March. So a small cohort of very excited women who've emailed me to say, hey, can we do this thing that we talked about? And I've been very happy to do it and very delighted that our prescribing software updated on the day. Very impressed.
Yeah, that was pretty good, wasn't it? Yeah,
I
noticed that with the contraception side of things. Yeah.
And so maybe just as a slight dive off to the side, not like me, Dr. Moz, we'll talk about why we're so excited about this gel. So it is better, much better for most women to use their estrogen across their skin rather than taking it by mouth as the traditional hormone replacement therapies were. And that's because it significantly reduces the risk of blood clots in the legs or the lungs or heart attacks or strokes. Because the estrogen, when you take it by mouth, has to get passed through the liver and get metabolized there. And that can upset your clotting at the simplest of levels. It's also safer for women who have high blood pressure or migraines. And interestingly, if women have any sort of gut issues, they might not absorb the estrogen properly. So it is now kind of state of the art to get your estrogen across your skin. Clearly, patches also do that, but patches have been not unavailable, very difficult to source
Really hard.
for several years now with no end in sight to that misery.
Yeah.
So it is wonderful that we have funding for an existing product that we have been using for some time, and most women are fairly delighted with it. There is one other gel. Sorry,
I was going to say, sorry, what's your experience with the patches versus gel? Because I feel like the both sides of the both camps are quite vocal in how much they hate the other camp. I think the people who like the gel, you absolutely will not stop hearing about how irritant to the skin the patches are, and the people who like the patches absolutely hate the fact that you have to put the gel on and then wait for it to dry, and then you got to do this drying dance or whatever. So what's your experience as someone who probably does far more menopause treatment than I do?
My experience is the same as yours, that the women are quite polarized. If they have started with patch, they want to continue with their patch. In terms of the estrogen, it's not that one is better than the other, but pragmatically, we're having a real tough time getting the patches, to the extent that we were issued with a recommendation, not told, not instructed to stop putting new patients on patches, but asked to consider not starting any new patients on patches, because you were just increasing the size of the pool of the women who every month were phoning around 1,000 pharmacies to try and source their patches. Yeah. So actually, that's the other announcement which has come out more quietly, is that our PBS have approved some overseas patches as equivalent. They've been added on. I think there's some from Germany and some from Canada, I think, have been approved as equivalent to things like Astellas Continuous. And the pharmacist is allowed to substitute that at the pharmacy for the Australian prescription that we've given. But these are all stopgap measures while we're still waiting for the supply to come in. What I will say is that while the Estrogel is a bit icky and sticky when you first put it on, once it dries in, there's nothing at all to see or feel. You just have to adjust your routine to put that on. The progesterone that comes, the partner progesterone for women who need progesterone, those who still have a uterus, the micronized progesterone that comes with the Estrogel, it is wonderful for helping with sleep, which is not the same. It's a different progesterone from the one that's in the patch. So for women who have significant menopause-associated sleep problems, the Prometheum, the progesterone that comes with the gel, is amazing for sleep. So, but again, it's wonderful that we live in a world where the two varieties are available. Previously, only the one variety was available on the PBS. And if you love your patches, we will help you as far as we can to continue getting them. The patch you only have to change twice a week, and you just put it on and you're done. Whereas the gel you have to put on every single day, and it takes 5 or 6 minutes to dry, and some people really can't be bothered with the spreading it out and waiting for it to dry. And for all individuals, I personally usually use the gel. I have used the gel historically. I changed to patches for my overseas trip last year, and I detested it because I spent the 3.5 days after removing it before the next one trying to get the blasted adhesive off. So so I detested that much more than I detest spreading my gel. But I'm one human being. That doesn't dictate what everyone else will feel.
No. Excellent. Fantastic. All right. Anything else to say on menopause hormone treatment, Dr. Anne?
I think, to be fair and to be complete, we will say that there is one other estrogen HRT gel which has actually been available for quite some time on the PBS, and that would be Sandrina. Sandrina is available, but fascinating, is not marketed with a specific partner progesterone. Sandrina is a smaller volume than the Estrogel, but apparently takes longer to dry. It also comes in individual little sachets, which can be a nuisance to open, I'm told. I'm led to understand. So there's swings and roundabouts. I guess having individual little sachets means that if you're going away for a weekend or a week, you can take the requisite number of little sachets rather than your gel. But I think Sandrina is going to lose out for women who need estrogen and progesterone now, because of the way the PBS pricing works. So with the Estrogel Pro, you will get both your estrogen and your progesterone for one cost, because they're packed together, they're co-packed. if you're somebody's on Sandrina and a separate progesterone, unfortunately, you will get 2 prescription charges every time because they are separate things that are not packed together by the manufacturer. So, but there's nothing wrong with Sandrina gel. It does the job. It is equivalent to estrogel. It just, for whatever reason, the manufacturer has elected not to market it with a partner progesterone. You just have to provide a separate progesterone.
Yep.
So I think that's our news. Better funding for women's stuff and better treatment for bacterial vaginosis. So another slightly girl-focused episode, Dr. Moz.
We can't help it if that's where the news is. Well, the news that interests us anyway.
Yeah, absolutely.
It's close to what we work.
I guess for the thinking male is actually good news as well, because you understand that getting treated will help your partner stop getting this miserable bacterial vaginosis. So there is something in it for the boys, I would suggest.
Yep. Excellent. All right. Well, if you've made it this far, we really appreciate your ears. Thank you very much for continuing to listen and support the podcast. Probably the thing that is most valuable to the podcast is if you felt that anything was particularly helpful in the podcast, give it a 5-star rating and share it with someone that you think might benefit from the information within. Do give us a follow on the social media channels. Find us on Facebook, find us on Instagram. We love hearing from people. So if you want to, comment on one of the Spotify links or on the YouTube links, or shoot us a direct message on Facebook or Instagram, we'd love to hear from you. Dr. Anne, thank you very much for your time.
And thanks for yours. Have a good week. See you next time. Bye.
Take care.